Welcome to the deep dive. Today, we're cracking open a really important set of notes, specifically focused on menopause. If you're tackling revision or just want a really solid, high-yield understanding of this topic quickly, well, you're definitely in the right place.
Absolutely. We've got these revision notes here. We're going to guide you through them, pull out the absolutely essential information. Our mission really is to help you see the forest of the trees, so you know what's most critical for understanding menopause based on this material.
Exactly. Think of this as your shortcut. We'll follow the structure of the notes, but really dig into the key facts, maybe some surprising details, and what ties it all together. So let's just jump straight in. Where do these notes actually start when defining menopause? What's the sort of fundamental concept we need to grasp first?
Right. At its core, the notes define menopause as, well, a fundamental biological event. It's really the point that marks the permanent end of a woman's reproductive capability.
And how is that defined clinically? Because getting that precise definition right is usually pretty crucial for revision, isn't it?
That's right. The key definition provided here is the permanent cessation of menstrual periods for 12 consecutive months.
Right.
And this needs to be spontaneous, so not due to surgery or medication or something else. The underlying cause, as notes point out, is the natural age-related depletion of those ovarian follicles.
Got it. So it's confirmed retrospectively then, 12 months after the last period. And when does this typically occur? Is there an average age mentioned?
Yeah, the notes give a general window, usually between the ages of 45 and 55. They specifically mention that the average age in the UK and, other similar countries tends to be around 51.
Okay, 51. That's a number to keep in mind. Now, what about the period leading up to that final period? Because, well, people definitely experience changes before then.
That transitional phase is called the climacteric. You'll also hear it called the menopausal transition, or, maybe more commonly, perimenopause. This is the time before the final period, when ovarian function is starting to decline, and symptoms often start to emerge. The important distinction really is that menopause itself is the event, confirmed after those 12 months of no periods, while perimenopause is the process leading up to it.
That distinction feels really important for clarity, yeah. And the notes include a practical point about contraception during this transition, don't they? Something about timing.
They do, and it's a point worth emphasizing, definitely. Effective contraception is recommended for 12 months after the last period if you're over 50. But note the difference here. If you're under 50, that recommendation extends to 24 months after the last period. That difference in duration based on age is a key detail to remember.
Absolutely. Easy to mix up. One final definition here. What if this whole process happens much earlier than that typical 45-55 age range?
All right, the notes cover this. If it occurs in women under 40, it's referred to as premature ovarian insufficiency, or POI. This affects about 1% of women, and it's characterized by amenorrhea, elevated gonadotrophins like FSH, and estrogen deficiency. Early menopause, on the other hand, that's the term used when it happens between the ages of 40 and 45. So POI is under 40, early menopause is 40-45.
Those are clear boundaries. Okay, so we've defined it. We know the typical timing and the terms for earlier occurrences. That leads us to the fundamental question, why does this happen? What's the underlying cause, the etiology?
Well, the notes lay out the primary driver very clearly. It's the natural age-related decline in the production of key hormones, specifically estrogen and progesterone.
And what causes that decline? Is it just, age itself?
It's tied directly to the ovaries. Over time, the supply of ovarian follicles, those are responsible for producing these hormones and releasing eggs, the supply gradually depletes. Once that pool is significantly reduced, hormone production just drops off.
So the ovaries aren't just getting older, they're sort of functional units. The follicles are actually running out.
Precisely. The notes highlight this as the core mechanism. As the follicles diminish, the hormonal feedback loop involving the brain, the hypothalamus, and pituitary that changes, you end up with higher levels of hormones like FSH trying to stimulate the ovaries, but the ovaries just aren't responding with estrogen and progesterone anymore.
That drop in estrogen and progesterone, is that what directly causes the periods to stop and then all the other symptoms? Can we get into the pathophysiology a bit?
Yes, exactly. That hormonal shift is central to the pathophysiology described in the notes. With significantly reduced estrogen and progesterone production, ovulation stops. And without ovulation and those subsequent hormonal fluctuations, the menstrual cycle ceases.
And the cascade of symptoms we associate with menopause, like the hot flushes and everything else.
That's a direct consequence of this really profound change in hormonal balance. Estrogen, in particular, affects so many systems in the body. The brain, bones, cardiovascular system, skin. the urogenital tract. So its widespread decline leads to that variety of physiological and psychological changes that the notes describe later on.
It's quite amazing how one shift can have such broad effects. We talked about early menopause and POI. Do these notes identify specific factors that might predispose someone to going through this process earlier than average? What are the risk factors listed?
They do list several, yes. Genetics can play a role, so a family history of early menopause can increase risk. Certain medical conditions are also linked, things like autoimmune diseases, thyroid issues, for example, or adrenal insufficiency, and also chromosomal abnormalities like Turner syndrome.
Okay, so underlying health issues. What about lifestyle factors or maybe medical history?
Lifestyle is definitely on the list. Smoking is highlighted as a significant risk factor for earlier menopause. Medical interventions are also key: surgical removal of the ovaries, which is oophorectomy, that obviously brings on immediate menopause. A hysterectomy, removing the uterus alone, doesn't cause menopause if the ovaries are left, but the notes imply that having both removed is a risk factor.
And treatments for other serious illnesses, cancer treatments.
Absolutely. Cancer treatments are specifically mentioned. Chemotherapy and pelvic radiation therapy are known to damage ovarian function and can induce early menopause.
Okay, so we've covered the what, the why, and who might experience it early. Now, let's think clinically for a moment. If someone comes in, maybe irregular periods, some hot flushes, menopause is one possibility, sure, but what else should be on your radar? What's the differential diagnosis according to these notes?
This is a really critical section for anyone revising, absolutely,
Yeah.
because you need to be sure you're making the correct diagnosis. The notes really stress the importance of considering other causes for changes in menstrual cycles and related symptoms before attributing them solely to menopause.
So what are the main culprits to rule out first?
Well, for any sexually active person presenting with recent amenorrhea, the most immediate and important differential is, of course, pregnancy. The notes explicitly highlight this. Always rule that out first. Beyond that, you need to think about conditions affecting the hormonal control centers in the brain. So, hypothalamic-pituitary disorders. These can disrupt the signals that regulate the ovaries.
What about things someone might be taking, medications?
Medications are absolutely key, yes. Hormonal contraceptives obviously can stop periods and mimic some symptoms. Other hormonal therapies, or even certain non-hormonal medications, can also interfere with the menstrual cycle. So a good medication history is vital. And the notes also list some conditions that are associated with menopause or become more common after menopause. It's important not to confuse these with differentials for the diagnosis itself. These are more like potential complications or things to be aware of long-term: cardiovascular disease, osteoporosis, urogenital atrophy like vaginal dryness, changes in body fat distribution. And they even mention a potential link to Alzheimer's disease, though they do note that research is ongoing there. So it's a subtle but important distinction for revision: differentials for the diagnosis versus conditions associated with the state.
That's a really helpful clarification. Okay, so rule out pregnancy, check hormone or pituitary issues, consider meds. Now, how common is this whole process? We know it's universal for women, but are there patterns in who it affects or how the age varies? What do the notes say about the epidemiology?
The notes reiterate that menopause is, well, a universal experience for women. The age of onset, as we said, averages around 51 in developed countries, but that average can shift based on several factors.
We already mentioned smoking and maybe low socioeconomic status being linked to earlier menopause. What else influences the age of the final period, according to the notes?
The notes list quite a variety of factors that can influence the exact timing. Things like the age you started menstruating your menarche, the number of pregnancies you've had, which is parity. Also, whether you've used oral contraceptives, sometimes linked to slightly later menopause, though the effect seems modest. Your body mass index, BMI, ethnicity, and, like we said, family history. It's clear it's not just one thing, but a really complex interplay of genetics, health, and maybe environmental factors too.
It's surprising how many variables are involved. The notes also touch on consultation patterns. Why do some women seek medical help for symptoms while others don't?
Yeah, this point in the notes highlights that access to healthcare is a factor, obviously, but it's also influenced by cultural perspectives on menopause, psychosocial factors, like how it's viewed or discussed within their community or family, and simply the severity of the symptoms they're experiencing. Not everyone's symptoms are bothersome enough to seek medical advice, or maybe they feel it's just something they have to put up with.
That makes sense. Now let's talk about the experience itself. What does menopause actually feel like for someone going through it? What are the classic clinical features, the symptoms listed?
Right. The first thing the notes emphasize is the huge variability in symptoms. Not everyone experiences the same things or with the same intensity. That's key. Symptoms typically begin in the mid to late 40s during that perimenopause phase before the final menstrual period actually happens.
And how many women actually experience symptoms? Is it most people?
But according to the notes, yeah, about 80% of women will experience some symptoms. And importantly, about a quarter of those, so 1 in 4, will have severe symptoms that really impact their quality of life.
Wow, 80%. That's a substantial number. And a quarter having severe issues. What's the most widely recognized symptom? The one everyone thinks of?
Unquestionably, that would be the vasomotor symptoms, so hot flushes and night sweats. The notes highlight just how common these are, affecting about 80% of symptomatic women. And here's a key detail for revision from the notes. These can often last for over 7 years.
7 years. That really puts it into perspective, doesn't it?
It does. That duration is often surprising to people.
Beyond the hot flushes, what are the other common or significant symptoms listed in these notes?
Well, as we kind of touched on, menstrual irregularity is often the very first sign during perimenopause. Cycles can become longer or shorter, more unpredictable, and this can last for up to 4 years before periods stop entirely.
And affecting other areas of the body. What else?
Yes. The notes list urinary and vaginal symptoms. These include things like dyspareunia, which is painful sex, vaginal dryness, sometimes an increased frequency of urinary tract infections, UTIs, and potentially urinary incontinence. These are often directly linked to the decline in estrogen affecting those urogenital tissues.
Sleep disturbances seem common too, based on the notes.
They are very common. Sleep disturbances frequently reported. And it can have a knock-on effect, right? It can worsen mood changes like anxiety, irritability, and maybe contribute to feelings of memory loss or difficulty concentrating, that brain fog people talk about.
Loss of libido is also listed.
Correct. The notes mention this and attribute it to, well, a combination of hormonal factors, but also broader psychosocial aspects, changes in life stage, relationships, maybe feeling tired or dealing with other symptoms. It's complex.
Any other physical changes noted?
The notes also include things like brittle nails, maybe thinning skin, hair loss, and generalized aches and pains. Again, often linked back to lower estrogen levels affecting connective tissues and possibly contributing to inflammation or bone health changes.
So it's a really diverse constellation of potential symptoms. Given this wide range, how is the diagnosis of menopause actually made in clinic, according to these notes? Is it complicated?
Actually, the diagnosis is described as primarily clinical. As we established right at the beginning, the definitive confirmation comes from that 12-month period without menses in someone of the appropriate age. After, and this is crucial, after you've ruled out those other important differentials we discussed like pregnancy or being on hormone-affecting medications.
Okay, so that leads us straight to the question of testing. If the diagnosis is primarily clinical, do we actually need blood tests or other investigations routinely?
This is a really crucial high-yield point emphasized in the notes. And it's a common source of confusion, I think. The notes state very strongly that diagnosis is primarily based on clinical history. For most healthy women over 45 who are presenting with typical menopausal symptoms, investigations are usually not recommended.
That's quite significant. So no need to routinely check hormone levels like FSH for most people in that age group?
That's exactly what the notes say for the majority of this population. Routine laboratory tests are typically not required in healthy women over 45 with classic symptoms. It doesn't really add much.
When would testing, like FSH levels, be useful then? The notes must specify certain situations, surely.
Yes, they do outline specific scenarios where it can be helpful. One is in women who are on hormonal contraception. Testing FSH can sometimes help guide the timing for when they can safely stop that contraception based on their menopausal transition status. FSH testing can also be considered for women slightly younger, specifically those aged 40-45, who are presenting with menopausal symptoms, just to help confirm if they are indeed in early menopause. And it should definitely be done in women under 40 if you suspect premature ovarian insufficiency, POI, because elevated FSH is a key diagnostic criterion for that condition.
Okay, so targeted testing based on age or specific circumstances like contraception or suspected POI, but not routine for the typical case. Are there any other important checkups that the notes recommend around this time?
Yes, they advise doing a cardiovascular risk factor screen for women over 40. This is important because, as we'll discuss, cardiovascular disease risk does increase after menopause. They also stress ensuring that routine cervical and breast cancer screenings are up to date, just following the standard national guidelines for the patient's age. Basic health maintenance, really.
And the notes explicitly list tests that are generally not helpful or recommended for diagnosing perimenopause or menopause in that typical over 45 age group. What are those tests we should generally avoid ordering for this purpose?
Right, this is another good list to remember what not to do routinely. The notes advise against testing LH, estradiol, progesterone, anti-Mullerian hormone, AMH, inhibin A or B, or doing things like an antral follicle count, AFC, via ultrasound, or measuring ovarian volume specifically to diagnose menopause in women over 45 with symptoms. These tests fluctuate too much during perimenopause or just aren't reliable enough indicators in this context.
That's a very clear list of what not to do. And just circling back one more time to that absolutely vital differential you mentioned earlier, the first check.
Right, just to hammer it home. For sexually active women with a recent short history of missed periods, the notes explicitly reiterate the need to perform a urine pregnancy test. Always rule out pregnancy first.
Okay, crystal clear. So once we have a clinical diagnosis or confirmation where tests were needed, like for POI, how do the notes suggest managing menopause? What's the approach to helping someone with these symptoms or the long-term changes?
The overall goal of management, according to these notes, is really twofold. First, relieving those bothersome symptoms that are impacting quality of life. Second, preventing the long-term health complications associated with the postmenopausal state. And the notes emphasize that management should always be individualized. It needs to take into account the severity of symptoms, the individual's medical history, their risk factors, and crucially, their personal preferences and values.
What's the foundational step mentioned? The non-pharmacological approach.
Healthy lifestyle is presented right up front as a cornerstone of management. This covers both symptom relief and long-term health. It includes encouraging habits like quitting smoking, aiming for a healthy weight, moderating alcohol intake, getting regular aerobic exercise, and ensuring adequate calcium and vitamin D intake for bone health. Simple lifestyle adjustments for symptom relief are also mentioned, things like reducing caffeine and spicy food, which can trigger hot flushes for some. Wearing layered clothing, using handheld fans, and managing stress is also highlighted as important.
What about medical treatments? The one most people think of is HRT, hormone replacement therapy.
Yes, hormone replacement therapy, HRT, is discussed as a very effective option. The notes state it's effective for relieving many menopausal symptoms and importantly also has benefits for preventing osteoporosis. They also mention potential benefits for cardiovascular disease risk reduction, though that can be complex. They specifically highlight its efficacy for vasomotor symptoms, the hot flushes and sweats, mood changes, and those troublesome vaginal and bladder symptoms like dryness or recurrent UTIs.
How is HRT typically administered or prescribed according to the notes? Are there different types?
The notes describe different regimens. It can be given continuously or sequentially. That depends on whether the woman is still having some periods or if she's been amenorrheic for a while. It can be taken orally as pills or transdermally via patches or gels. The transdermal route is often preferred nowadays if there are concerns about blood clot risk, though the notes don't delve deeply into that specific risk stratification. Topical HRT, like vaginal creams or pessaries containing estrogen, is specifically mentioned as very effective and often the first choice for treating isolated vaginal atrophy symptoms, as it has minimal systemic absorption. The notes also suggest that psychological symptoms like mood swings may improve with HRT, or potentially through cognitive behavioral therapy, CBT, and they acknowledge alternatives are available if HRT isn't suitable or desired.
Right. What if HRT isn't an option or someone prefers not to use it? What non-HRT pharmaceutical options are listed for specific symptoms in these notes?
Okay, for vasomotor symptoms, the hot flushes and sweats the notes outline a kind of stepped approach for non-HRT options. The first line mentioned are certain antidepressants, specifically SSRIs, like fluoxetine or paroxetine, and SNRIs like venlafaxine. If those aren't suitable or don't work, gabapentin, which is actually an anti-seizure medication but works for nerve pain and hot flushes, is listed as a second-line option. And clonidine, an older blood pressure medication, is mentioned as a third-line choice, though may be used less often now due to side effects. For vaginal dryness, the notes reiterate that vaginal HRT is very effective, but also mention the use of non-hormonal vaginal moisturizers and lubricants. For reduced libido, they note that combination estrogen-androgen therapy may be considered in some specialized cases, but that's usually under specialist guidance.
There was a specific point in the notes about managing early menopause differently, wasn't there? Something about long-term risks.
Yes, that's a really key point. Because women experiencing early menopause, or POI, lose the protective effects of estrogen much earlier in life, they are at a significantly increased long-term risk of osteoporosis, cardiovascular disease, and potentially dementia. Therefore, the notes suggest considering higher doses of HRT for severe symptoms in this younger group. And crucially, for women with diagnosed early menopause or POI, the notes state that the benefits of HRT in terms of reducing these serious long-term health risks usually outweigh any potential risks associated with HRT itself, especially when it's continued until at least the average age of natural menopause around 51.
That seems really important for that group. Are there recommendations for ongoing checkups beyond just managing symptoms?
Yes, the notes just briefly reiterate the importance of encouraging continued participation in routine cervical and breast cancer screening programs, just as per the standard age-appropriate guidelines, keeping up with general health screening.
How does the overall prescribing strategy look according to these notes? When do you jump to medication?
The notes indicate that pharmacological treatment, like HRT or the non-HRT options, is typically initiated when symptoms are significant enough to interfere with a woman's daily life and well-being. As we discussed, different types of HRT are available depending on needs combination therapy with estrogen and progesterone for women with a uterus, estrogen only for those without. Non-pharmacological management, like those lifestyle changes, is the primary approach for mild symptoms or for those who cannot or choose not to use HRT. And there's a useful word of caution in the notes against using unregulated herbal products. Their efficacy often isn't well established by rigorous studies, and they can have potential interactions with other medications or even side effects.
Good point. And when might someone consider stopping HRT if they started it?
The notes suggest that if HRT was started primarily to manage vasomotor symptoms, attempting discontinuation after maybe 2 to 5 years can be considered. It's often reviewed annually. They mentioned that gradually reducing the dose might help manage symptom recurrence in the short term when stopping, but interestingly, the notes clarify that the method of stopping, whether you taper it slowly or stop abruptly, doesn't seem to make a difference in long-term symptom control. Symptoms might come back either way for some people.
Okay. Finally, on management, when would the note suggest referring someone to a specialist or secondary care?
Referral is indicated in a few situations.
Uh-huh.
If treatment isn't effective in controlling symptoms, despite trying appropriate options, if the patient experiences ongoing or troublesome side effects from treatment that can't be managed, or, very importantly, for investigation of any unexplained postmenopausal bleeding. Any bleeding after 12 months of amenorrhoea always needs further assessment, usually involving an ultrasound and potentially a biopsy.
Right, that makes sense. We've covered a lot, from definition and cause right through to symptoms and management. Let's wrap up by looking at the long-term view. What's the prognosis for menopause itself, and what are the potential long-term health implications outlined in the notes?
Well, the notes emphasize again that menopause is fundamentally a natural biological process. It's not a disease or a condition to be cured. And reassuringly, for most women, the acute symptoms we discussed, the flushes, the sleep issues, etc., they tend to improve and eventually resolve over time. Though, as we noted, that duration can vary widely, sometimes lasting many years.
But there are significant long-term health considerations that arise from the postmenopausal state. The loss of estrogen has lasting effects.
Absolutely. The notes stress that long-term follow-up and attention to health is important precisely because of the physiological changes that occur after menopause, particularly the loss of bone density and changes in cardiovascular risk factors. These require ongoing awareness.
This brings us to the potential complications. The notes list the increased risks people face after menopause due to these changes.
Yes, the decline in estrogen leaves women at an increased risk of several significant conditions. The notes specifically list osteoporosis, due to accelerated bone loss, increasing fracture risk, cardiovascular diseases like heart attack and stroke, as estrogen has protective effects on the heart and blood vessels that are lost. Also, urogenital atrophy, which can cause chronic symptoms like vaginal dryness, pain during intercourse, and recurrent UTIs. Mood disorders, such as an increased risk or recurrence of depression, and potentially changes in cognitive function, though the link here is still being actively researched. The positive takeaway here, though, which the notes implied through the management section, is that while these risks are real, many are modifiable or manageable. Proactive steps like those lifestyle changes we discussed, appropriate screening like bone density scans or cardiovascular risk checks, and considering therapies like HRT or specific treatments for bone health when indicated can significantly help mitigate these long-term risks.
So, while the immediate symptoms often fade, the shift in the underlying health risk profile is enduring. It really requires ongoing attention to preventative health strategies.
Exactly. It marks a transition point for focusing on long-term health.
Okay, well, we've taken these revision notes and walked through the definition, the why behind it, the risks for early onset, what else it might be, how common it is, what the symptoms feel like, how to approach investigations crucially, when not to investigate the various ways to manage symptoms and long-term risks, and finally, the overall prognosis and potential complications.
Hopefully, this deep dive into the notes has helped consolidate the key information for your revision. Remember the core definition, that 12-month amenorrhea rule. Remember, it's primarily a clinical diagnosis in women over 45. Keep in mind the big bucket of common symptoms, especially vasomotor ones. And be aware of the main management approaches: lifestyle, HRT, non-HRT options, and crucially, those long-term risks like osteoporosis and cardiovascular disease that need ongoing attention.
Thinking about that split, the natural process versus the long-term health implications, here's maybe a thought to leave you with. If menopause is a natural transition, yet it fundamentally alters a woman's long-term health trajectory, how does really understanding this transition shift the conversation? Does it move us beyond just managing temporary symptoms towards prioritizing lifelong preventative health strategies starting in midlife? Something to ponder. Thanks for joining us for this deep dive.
And for more resources specifically designed to help with your revision, you can definitely explore PassThemSRA.com.
Yes, and there are also valuable free resources available to help you continue your learning journey over at freemsra.com. We'll checking those out too. Until next time.